Hi, well, welcome to our shared patient experience talk. I think most of you are familiar with our organization, which tries to encourage the sharing of knowledge on patient experience across hospitals and other care organizations across Europe. We organize regular talks. This one will be in English. We also have talks in French. It will last till 12:30, and we will stick to the timing to respect everybody's schedule. We are very honored today to welcome Mark Duman. He is as his title slide says, he's a Chief Patient Officer, but he has also a lot of other hats, which I'm sure he will talk about. He is
literally.
He's an expert, if there ever was one, on patient experience, and he has a couple of topics that he wants to share with us in this half hour. I think Mark will speak for about 20 minutes, and then we'll have some time for Q&As. So get your questions ready. You can share them in the chat ahead of time, or you can just ask them at the end of the talk. The talk is being recorded, so if anybody has a problem with this, let us know now. And I think I will end my introduction there. Mark, the floor is yours.
Thank you very much for the opportunity. I'm Scottish, so I'm going to try and speak English. If I need to slow down, let me know. I don't think we have subtitles, but thank you all for allowing us to speak in English, which is supposedly my mother tongue. I don't speak Gaelic. I'm a pharmacist by profession. I've been a management consultant for 25 years, and I'm a patient with type 2 diabetes. I bring literally those three hats to bear in all the work that we do. I'm not here to advertise, but we run a small company called MD Healthcare. I am the Chief Patient Officer, A, because I can call myself any name I want, but B, more importantly, I'm trying to get the concept of the chief of the patient being at the board level. That includes patient experience, it includes health coaching and moving away from an overly medical model in healthcare to one that embraces prevention, self-care and self-management. My last slide will be contentious and challenging and says that hospitals are generally bad places, so forgive me, but I'm starting off by saying the healthcare system is focused on looking after itself and is not focused on looking after patients primarily. And we all have good intention, but we all get paid primarily for people being ill, not for people being well. So they are not healthcare systems, they are illness systems. And I say that as a patient with type 2. I'm working with patient advocacy groups, and I don't want to get your backs up. I don't want to start the talk off by being difficult. I just want us to think a little bit about where does patient experience really exist at board level. We have in the UK something which I haven't touched on in detail called the Friends and Family Test, which is bringing the Net Promoter Score idea into healthcare. I think it's great to bring customer experience measures into healthcare. And patient experience measures into healthcare. In the UK setting or in the English setting, I don't think the Friends and Family Test is the right measure, but it's the right concept. And today, what I'm going to touch on, and I'm open, I'll give you my email and my LinkedIn at the end. I will try to stick to 20 minutes, but unfortunately, as a creationist, I don't follow the rules of speaking twice as much or listening twice as much as I speak. I talk too much. And I'm aware of that, so I'll try to keep focused, but I get too passionate. I wear my heart on my sleeve, and that may come across. And I think that's an important thing, because ultimately we're in the business of healthcare. We're not in tobacco, we're not in armaments. We are there to do good things. But sometimes our organizations look upwards and don't look outwards too much. And I think things like complaints or gold dust, you know, these are wonderful opportunities to improve. I often say to hospitals, you want to increase complaints. And they're like, what? I say, not necessarily medical negligence, but from a patient experience point of view, the more compliments and complaints you're getting, the more insight you're getting on how to do things well and how not to do things. So happy to pick up on stuff as and when. I'm going to touch on three Very interrelated topics. I have 2 slides for each, and I will go through this quite fast, and I'm going to throw a lot at you, but as I've said, happy to pick up separately. I'm exploring with XPX strategically how we might do something either in my own role or with some of the organisations I work with, which I'll share with some of them with you later, in order to bring the UK perspective to some of the things you're doing, and equally importantly, to learn from you guys and what you're doing in your respective areas. So today I want to reframe the information that we give to patients. It's often seen as a nice to have as opposed to a must to have. And I think I saw something on LinkedIn today from a general practitioner who specializes in diabetes in one of my areas. And he said, educate before we medicate. And I thought, what a lovely phrase. We spend a lot of time personalizing medicines. Do we spend sufficient time personalizing information? Both in the construct of informed consent. Do we focus more on the medical consent? Let's make sure the patient is consented. Or do we focus on let's make sure the patient is informed? And as we know, 20% of operations that occur where a patient suitably informed would not take place. So, and in fact, don't necessarily show improved clinical outcomes. So again, we need to be beginning to look at informed consent, not as a medical legal type of tick box, but as a patient empowerment, a true shared decision-making opportunity. So I'm going to touch a little bit on that. And as I said, I'm probably going to create more questions perhaps or more topics to explore in the future than I'm going to give you answers. Everybody gets co-creation. Joop said that and Tom has said that, but I'm just going to touch on a couple of things. And I'm going to try and provide you with practical links throughout. Whether you want to follow them, depending upon your capacity and capability, is completely up to you. And then I'm going to conclude with the idea that health psychology, I think, is the missing ingredient in healthcare. And I'll talk a little bit my own personal story of trying to put my diabetes into remission. So just jumping into information as a therapy, how do we personalize education to activate patients? What is the goal of information? Is the goal of information to simply inform, or is the goal of information to enable and to educate and for patients to participate, to activate? All these terms, ultimately what we're trying to do, and we'll come to this at the end, is to provide information and education to elicit behavior change. I will hopefully lose weight before I have to come into surgery to reduce my risk. I may indeed follow a prevention, a self-care, a self-management routine in order that I don't have to get unwell or even more unwell, and I can begin to self-manage my condition as I'm perhaps trying to do, and to be honest, struggling to do. I was told it was okay to share UK resources, so that's what I've focused on today. There are international aspects of some of this stuff, although I have not come across a patient information forum at either European or indeed global level. There was in the States a decade ago something called the Centre for Information Therapy, but it stopped functioning. PIF, I'm glad to say, we founded back in 1997. It is still going strong, 27 years later. Go and have a wee look at PIF. There's lots and lots of free opportunities, free resources, I mean. They run webinars, they run training courses. It's all about how to produce great information for patients, family members, caregivers. One of my favorites, and we've updated it now 3 times, I helped found the PIF. I left 7 years ago, but like a parent and a child, I'm still sort of keeping an eye on them, trying to let them do their own thing, but you know, and thinking, oh, I wouldn't do it that way, but I try not to read their monthly newsletter, but I'm still very firmly attached. And if you look at PIF, you'll see a whole bunch of guides and opportunities. And one of my favorites is how to produce information for children and young people. They're not simply small adults. We need to think about fragmenting and segmenting the audiences, to be thinking about different age groups. You know, adults we often think are above 18 and one, homogenous mass. That's not true either, as we know. But again, please do have a look at PIF. They look at topics we'll touch on briefly later around health literacy, around digital literacy, around accessibility. I think there's lots of stuff there you could potentially pick up on. We don't have a French or a Spanish version, forgive us, we're English, but given that you're having this talk in English, I think you'll find, I'd be interested, maybe don't feedback to, well, feedback to me, feedback to them. I'm not involved or trying not to be involved in PIF, but I'd be interested in what you think, if there's stuff there that's useful, if you have time to go and look at it. Why information? As I said, it's not about the passive side of information. We've produced an information leaflet. We've produced something for you to sign off for informed consent. Outpatient departments. What a wonderful opportunity for a captive audience sitting, waiting for an appointment to be educated, to have video screens, and you may already do this, educating them about lifestyle changes, about opportunities to get involved in clinical trials or in research. What is shared decision making? What is this world of personalized medicine and genomics that coming? Small 1-minute clips, either from your own libraries or that taken that's approved. And again, we need to talk about approval and how you approve health information, but that's taken from YouTube or whatever, really to use those opportunities, not just for people to sit on their phones doing stuff, but even market the hospital, even market the services that you do. But there's a captive audience sitting in waiting rooms who, for the price of a screen, and in some cases you have to put the screen in a metal case and protect it from being stolen. We have that here in the UK. But there's opportunities to educate, to market to your patients. What's the goal? Not to keep them as a passive patient and be a passive recipient of care, but to move them to be an activated, participant. So they can be a passive recipient on one side at level 1, we'll touch on this in a minute, or they can be an active participant at level 4. And ultimately, I, as a healthcare professional, was never taught how to be. I was taught to talk about medicines. I was taught to talk to patients to elicit their views, but I was never taught to be a health coach. So I was taught to be a caregiver, but not a coach. And one of the things we need to do in global healthcare systems, given the infinite demand but finite supply, is to really try and focus a lot on how do we get our patients to become more self-reliant. Some work, and that's where we need to focus on doing this stuff. Again, if you haven't come across the patient activation measure, a bit like the friends and family test we touched on, great idea in terms of how do we actually measure how engaged a patient is. Now, the patient activation measure came from the University of Oregon. For some, there is some questions about its validity academically, but it's a useful start in terms of bringing a measure into healthcare that begins to look at the motivation level, the activation level, the participation level of the patient. And why do I say that? Because the PAM measure, with its pros and cons, puts patients into 4 different levels. And again, it doesn't work perfectly because sometimes you can have a patient activation level in one condition that is not echoed in another one of your conditions. So you can be active in one condition, but not active in them all. So it's a wee bit unidimensional, but it's the concept is there. And this is where behavior change comes in and health coaching comes in. I'd suggest that what our job's to do, whether we're in secondary care in hospitals, in primary care, in community care, in pharmacies, in community health workers, whether we're doing what we call social prescribing, is really to try and move a patient from level 1 to level 4. And that's not just an ethical or a moral imperative, it's also a financial imperative. Because what you do is if you move a patient from level 1 to level 4, and it's not easy, healthcare systems can save between 8 to 21% of costs. And I do not know any healthcare system in the world, unless they are focused on their own revenue streams in isolation, that wouldn't like to see an average 10%, 12% reduction in their costs through activating patients. It's not nice to have, it's a must-have. And part of activating patients is getting them involved right at the beginning. I don't know if you can see this, but I'm blessed to a year, literally in a week's time, to have become a grandfather. One of the first things I wanted to buy my granddaughter in terms of baby experience was a mobile, one of these little baby things that goes around her cot. And I saw this in terms of co-creation. I bought this lovely little thing for my granddaughter to look at. All she sees is 4 animals' bums, backsides. So from her, I've done the right thing. I've done a thing. I've bought this thing, but ultimately, from her perspective, I'm teaching her that you should really look at animals' bottoms. And in a way, I love the picture because what it says is often we look at our patient experience from our perspective and we don't create it with the end users. You know all this stuff, as I've been told, but I think the visual just encapsulates it really nicely. I work with lots of digital health companies where there are medics and technologists who are really bright and enthusiastic and passionate and want to make a difference, but have not talked to any end users. And what they end up having is a solution looking for the problem, as opposed to a clearly defined problem that is looking for a solution. Again, talking about ways to facilitate and help you do your jobs better. If you have the time and the capacity and the desire. IDEO, who many of you will know, who, if you're into human-centered design and user experience, are one of the world leaders in this area, have produced something called the Design Kit. Well worth looking at. It gives you tips and insights and a whole bunch of stuff that allows you to bring human-centered design into the products, but more importantly, perhaps in our world, the services that we have. My own quick experience, which I call the X-ray sandwich, is having coughed for 12 weeks, going down to my, getting a referral, going down to my hospital and on a conference call saying, guys, I don't know how long I'm going to be. I know there's still an hour to go in the call, but I might not be back on it. I'm going to hang up now, and if I can find time to come back in the call, I will. I'm going for an X-ray at an NHS hospital, so I might not be speaking to you again until later in the week. Goodbye. Hung up. Walked into the department, handed them my referral slip, in and out in 4 minutes. I was like, oh my goodness. I went up to the clerk at the desk and I said, that was amazing. And she went, who are you? And I went, I'm a happy patient. She went, really? I said, yeah. She went, what are you talking about? I said, look, I'll be really honest. My expectation was to come in here, was to sit in the in the waiting room for whoever knows how long, go in, get gowned up, wait for this, wait for that, all the rest of it, and I don't know how long it would take. I literally didn't even sit down, went up, said I'm here, a nurse came and got me, gave me a gown, got gowned up, went in, had 2 X-rays within 2 minutes, came out, got dressed and left, and I'm now talking to you again. That was amazing. That's a great patient experience. Now, why I call it the X-ray sandwich, because I then turned around to her and said, could I have a copy of my X-ray? And she went, who are you? And I went, I'm a patient who doesn't want to wake a week thinking I may have lung cancer and who has a friend who's a radiologist who can look at my X-ray. Here's my memory stick. Can you stick it on there? No, it's not your image. The referral to get there, I had to go to a GP, a general practitioner. I had to stand in a queue. I had to fill in a form. They had to hand me a handwritten piece of paper, which was the piece of paper I then took down. So the X-ray was great, but the bread on each side of it was stale. We need to, as you know, not just look at the experience that I have in the hospital, right? But what's the patient pathway, or even better, the patient odyssey? Because it's not a pathway and it ain't a journey, it's something I don't want to be on. But that's something that, again, hospital care is not the be all and end all. How much can you influence it? I'm not sure, again, how your healthcare systems work, but it's about end-to-end engagement. And that's what the design kit and other things begin to look at. The other thing I would look at, and this again is focused on social care, because we have had a split for many years in the healthcare service in the UK where there's health and social care. We brought them together. But there's guides on co-production that comes from the Social Care Institute for Excellence, well worth looking at. There's training, there's a whole bunch of stuff there about how we really bring co-production into social care and into more broader areas. I'm a big believer that if we can get people with additional neurodivergent needs and more learning disabilities and social care needs, if we can cater to them, we can also cater to broader patient groups as well. And if you really want to do some stuff on it, there's an online, I think it's an 8-hour course that you can sign up for and have a wee look at creative thinking and get yourself a little certificate. So there you go. We can add to your resume. Lastly, keeping an eye on time, a couple more minutes. I've said that health psychology is the missing ingredient in healthcare. What do I mean by this? I mean that as a patient with diabetes, my healthcare system has talked to me for 10 years prior to me beginning to get a different mindset about my HbA1c, my LDL, my BMI, an alphabet soup of medical acronyms They even to a pharmacist really do not resonate and really don't mean anything to me. But I only spend an hour a year touching the healthcare system, right? The rest of the stuff is about my financial issues and how my physical issues, my mental health issues. I am not just a broken pancreas. I am not just a patient. I am a whole person. And sadly, what happens with the healthcare system is we break us down into body parts, and my endocrinologist deals with my pancreas, and my hepatologist deals with my liver. And when I had mental health problems, there was my psychiatrist. The only person who integrated all of that healthcare was me. And when I couldn't do it for mental health issues, was my wonderful wife. We're not into directorates. We're not into looking at things through body parts. And yet we do. And we become increasingly specialized, and in doing so, we lose the person in that. We need to see the patient beyond the pancreas and the person beyond the patient, and think about the whole holistic approach to things. In all of our surveys, are you getting back to work? Are you playing more with your grandchildren? Do you feel more able to manage your own health? Not just what was the quality of service you had. And again, if you're scoring very high on your quality of service and your satisfaction, and I don't think satisfaction should be a measure at all, I think you're asking the wrong questions. I want people to be telling me what they want improved. I don't want information that tells me how good I am. I want information that tells me how to improve. And just to take it down to the personal level, my screen has frozen. Let's do it manually. When I go and see a healthcare professional, they know about my past medical history, my current medication. They know about my communication preferences at the top of the pyramid. But what they don't really know with me as a diabetic, and I use that term intentionally, do I have a touch of sugar, which my grandmother has and she's 112? Or do I have a life-threatening illness that took my dad too early 15 years ago? There's a validated questionnaire that allows me to collect that data, and it's short. There's also a short questionnaire that asks about my medicine's beliefs. Is the medicine I'm taking a poison, or do I think it's a cure? What are my health and digital literacy needs? And lastly, what's my degree of motivation? Back to the activation stuff. And lastly, in the context of seeing me not as a pancreas or as a patient, but seeing me as a person, I've had some real issues this last 10 days with my 14-year-old kid. My diabetes control has gone out the window. I've been doing emotional binge eating because I can't cope emotionally with what's happened to him. So at the moment, my healthcare doesn't really matter. The same way as patients will turn up and being told the best prognosis for you is to start chemo right now, and they'll say, well, I wouldn't want to start for 3 months because I want to attend my daughter's wedding and have a full head of hair. So again, we need to see things beyond our often very myopic view of healthcare within my settings. That's personalized medicine. As someone at the FDA in America said, personalized medicine is not giving a homeless person a medicine that needs to be refrigerated. Simple, but a much bigger perspective on what personalized medicine is. And lastly, as I said, we need to move away from this selfish, greedy 88% expenditure on healthcare systems. 50% of what we do in healthcare is our behavior, 20% is the environment, 20% is genetics, which we're now beginning to change, right? But only 10% of my determinant of healthcare is actually my access to care. And yet we spend 90% on that and only 4% on behavior. So hospitals, dare I say, need to be promoting health, not just treating illness. And with that, I'll leave you a whole bunch of things not to look at now, but to get the slides and to click on some of this stuff, a whole bunch of things out there, from an article through creating information with patients, a whole bunch of other bits and pieces. But thank you. Now I'm going to have a drink of my coffee because I'm getting
Great, Mark. Thank you very much. This was very interesting and brought in a very entertaining way. And I think we all managed with your Scottish accent. So thank you. Thank you for making an effort. Are there any questions? I mean, I have tons of questions, but I will put it to the floor first. Tom, you have a question?
Yeah.
Go ahead.
Thanks first of all, Mark, for the excellent presentation. I wasn't be able to be there at 12 sharp, but I managed to join most of your presentation. I got a question regarding your first topic on the information topic. There's lots of new technologies strolling around, like generative AI and things. Do you think they can play a positive role, or will they even increase the literacy gap between the haves and the have-nots? What's your opinion on that?
Both. I think what we're seeing is, for example, I'll give you an example. I think information is absolutely mandatory and has to be something that is built into, back to my point about informed consent. The focus has to be informed, not just the consent. And we need the Montgomery Law, I think back in 2018 or 19 here in the UK, actually changed the consent law for medics. They don't have to prove consent, they have to prove how they actually inform the patient. So I think for us, we really need to move away from just sign this and this to really informing patients. And for us to do that, I think generative AI comes in. We've all seen the study, I'm sure, that shows that it's more empathetic potentially than doctors, which is interesting. And if I were a doctor, I'd be thinking, okay, maybe I need to work on my personal communication skills if a machine's beating me. But I think technology is here to stay. I think it needs to be tailored to the individual like anything. And that's the key, is how can generative AI perhaps tailor that information as a therapy in the same way that we do medicines. So we'll tailor a medicine for renal function, for age, and for lots of other parameters. I think we need to be doing the same with information. And I think technology can help us do that and help us deliver that better as well.
Yeah, thanks.
Great answer. Is there anybody else with a question? Otherwise, I will have my own question, if I may. You touched, Mark, on the economic drivers, to invest more in patient experience. Yet we're seeing, at least in many of the European countries, and I think the same is true in the UK, that investments are lagging, and that every time it's very difficult to convince people to make those investments. Do you have any bright ideas on the subject? I mean, is there anything that can help?
Yeah. I mean, we're currently doing work more in the pharmaceutical area, where we're trying to put something. We started calling it return on investment, and then we're not allowed to do that. So we called it return on engagement, and we thought, no, we can't do that because it's return. So we started calling it value, and then we got into trouble with compliance. So we're now calling it impact. I would like each of you to think about, where can you show an impact on where patient experience has reduced use of service, has reduced length of stay, has made a patient more resilient. And again, not, as we've said, within your own four walls, but about having a patient leave the system and not have to come back ever, or at least for a longer period of time, or for them to be able to return to work. We need to be looking at patient experience measures that include activities of daily living and quality of life, not just within a hospital setting. The second thing, with time running out, is could we please stop thinking that patient experience is only important enough for nurses? This needs to be something that the chief medical officer owns and looks at and works with the chief nursing officer on, and is equally important to the chief finance officer and the chief executive officer. It is as important as patient safety, is as important as clinical effectiveness. It needs to be the third part of the definition of quality in healthcare. And we in the UK did this back in 2000 with the NHS plan. Patient experience is still the runt of the litter, but we need to get it out of it's nursing, because they do most of the contact, and right up to board level, that it's something that's on the dashboard of how they operate hospitals, if it's not already there.
Great, Mark. I'm very sorry, because we said we were going to respect the timing. It's 12:30. I'll just finish by thanking Mark, by thanking all of you for attending, and just to make sure that I make my president or our president happy. I'll put in a little plug for our annual colloquium, which is taking place in October. You're all very welcome. If you haven't registered yet, please take a look on our website. And this concludes our talk. I very much look forward to seeing you again in our next talk after the summer. Enjoy your holidays. Thank you, Mark.
And I'd love to know what the experience was. So please email stuff you didn't like, so that I can improve, or tell me things you did like, and that will make my wife and me happy. Thank you so much.
Okay. Thank you. Enjoy your day.